Good morning and welcome to the 22nd meeting in 2013 of the Health and Sport Committee. And as usual at this point in time, can I remind all of those present to switch off mobile phones and Blackberries, as they can often interfere with the sound system. I draw to the attention of all those here that you may also notice that some of the members and officials are using iPads, and this is instead of the hard copies of our committee papers. Item 1 on our agenda is the registration of social workers and social service workers in Care Services Scotland, Regulations 2013 draft. And can I welcome from the Scottish Government for the first time, I think, to this committee, Aileen Campbell, Minister for Children and Young People. Welcome, Minister. The Minister is accompanied by Diane White, Senior Policy Officer, and Roddy Flynn, Senior Principal Legal Officer. And I invite the Minister to make an opening statement.
Thank you, Convener, and thank you for the opportunity to introduce these regulations made under the Public Service Reform Scotland Act 2010. These regulations largely replicate processes that have been in place since March 2009. The draft regulations before you are a consolidation of 3 separate sets of regulations currently in force, which require social service workers to register with the Scottish Social Services Council (SSC) in order to work in the sector. The 3 existing sets of regulations set dates by when all existing workers working in services within the scope of registration must achieve registration, introduce the requirement that workers employed for the first time in specific groups must achieve registration within 6 months of commencing employment, and create an offence if service providers failed to comply with the requirements of the regulations. The consolidation of the 3 separate sets of regulations into the draft instrument before you simplify the application of the regulations, making them clearer and more concise. The consolidation exercise also provided the opportunity to introduce an amendment to the regulations and introduce a new provision in relation to the regulation of the social services workforce, those being amend the regulations to widen the requirement to achieve registration within 6 months of commencement of employment to all workers within the current scope of registration, and provide the SSC with a statutory power specifically related to the registration of workers employed in daycare of children's services provided on a seasonal basis, for example, summer play schemes. Now, I'll deal with each of those changes separately. Firstly, amending the regulations to widen the requirement to register to all new workers. When the initial regulations were introduced in March 2009 in response to concerns raised by the sector, the requirement for new workers to register within 6 months of commencing employment was only applied to a limited number of workers. Subsequent regulation placed the requirement on further groups. However, in agreeing to progress with a limited number of groups in the first instance, it was made clear that the requirement would be placed on all other groups as soon as reasonably possible. The draft regulations before you contain the provision that all new workers commencing employment in any of the groups within the scope of registration must achieve registration within 6 months of commencing employment. That provision will ensure registration with the SSC will become a matter of course for all new workers in the sector. Turning to the second change, when registration of workers in daycare of children's services commenced, the SSC received representation from providers where the service was provided on a seasonal basis, for example those summer play schemes that I mentioned, and that the standard approach to registration would be disproportionate for their workers. The SSC held discussions with the sector and then consulted on a proportionate approach to registration of workers employed in a seasonal service, and received a favourable response from the sector. The consultation on the draft instrument specifically asked for comments on the proposed proportionate approach to registration, and the majority of responses agreed with the proposals that were put forward. The provision contained in this draft instrument will provide the SSC with the statutory power to register workers in daycare of children's services provided on a seasonal basis in that proportionate manner, recognising the uniqueness of that service provision. So in summary, the regulations maintain and fulfil the policy intention that registration with the SSC is a prerequisite of employment and continuing employment. It will simplify the application of the regulations. It will clarify the requirement to achieve registration within 6 months of commencement of employment applies to all workers within the current scope of registration. And finally, it provides SSSC with the authority to take a proportionate approach to registration for workers employed in services provided on a seasonal basis. So I move the regulations and happy to take any questions, Convener, that you or the committee may have.
Thank you, Minister. Do we have any questions? Annette Millen, followed by Richard Lyle.
Question. I noticed that the annual registration fee will be paid by individual workers. How much is that registration fee, and do you think it will have any impact on recruitment levels?
Again, these are always been done in a kind of proportionate way, recognising the salaries that some of the workers may have. Diane, do you want to answer that? But certainly it's always been done to make sure that it's mindful of the finances of that particular worker.
The registration fees currently are £30 for managers and social workers, £20 for the practitioner and supervisor, and £15 for support workers, and £10 for students of the social work degree. That's an annual fee.
Richard Lyle.
And hopefully that fee will not be updated. Morning, Minister. Can you advise the committee how many people does this regulation affect, and what happens if someone doesn't achieve registration in the allotted time? What would happen? Sorry.
Thank you for the question, Richard. And it's about making sure that there's a kind of timescale there to give them the opportunity to achieve the required registration, to have a kind of period of grace. As for the numbers, I mean, Diane, do you have the numbers about how many?
Currently at the moment there's about 58,000 on the SSC's register, and by the time the scope of registration is completed for the first two phases, there'll be about 140,000 workers involved in the social services that will be registered with the SSSC. Mm-hmm. That would be by 2020. Mm-hmm.
But there is a period of grace there to allow folk to work towards getting that
Yes,
registration.
there is. People can register subject to the condition if they don't have the qualification, that they work towards attaining that qualification. What would happen is they have to apply now within 6 months. They can achieve it if they satisfy the conduct and character criteria. Then the SSC can impose a time limit on when to achieve the qualification.
Thank you very much.
Drew Smith.
Just two very brief questions. One is just around the length of time that it takes to register. So, particularly thinking about those people who might be registering over the summer period, that they will get whether they're delayed being able to work while the process of registration goes on, and how long that might take, and whether or not it is an annual registration. You know, how does if for example, well, I suppose the question is does registration only relate to one employment? So if a student was to register for work over the summer, it's quite a brief period, do they then have to go through that process again, you know, the next time that they want to take up work like that?
In terms of, I take it you're referring to the kind of seasonal issues, and there's a provision within the bill there to try and be a bit more reflective of the fact that it is seasonal and to be proportionate as well. So if it's one summer, it's they don't have to register, but if there's a kind of more of a regularity to that seasonal work for that particular person, then there is a requirement for them to work towards becoming registered.
Okay, no other questions from committee members? Thank you. We now then move to agenda item number 2, which is a formal debate on the affirmative SSI, on which we have just taken evidence from the Minister. I remind members that this is a debate, so there is no further questions that could be put to the Minister at this time. I also remind officials that they are unable to participate in that debate. And I invite the Minister to move the motion S4. Do you want to ask if anyone has any points to make in the debate first? Sorry. Oh, sorry. Is there any why is this? Just if you ask for any points to make, if anyone has any points to make following that. From the Minister? No, from members. Sorry. I should have asked the members. That's where I went wrong. I'm trying to get through that. Do the members wish to participate in the debate? Does any member wish? Can I invite the Minister to move motion S4M 07083, previously referred to and laid out before us? Thank you. As no member wishes to speak in the debate, can I invite the Minister to sum up in that said debate.
I can waive my right to sum up.
Thank you, Minister. Thank you, Minister. Thank you. Then we put the question to the committee on S4M 07083 that the Health and Sport Committee recommends that the registration of social workers and social service workers in care services Scotland Regulations 2013 draft be approved. Are we all agreed? Thank you very much. And can I thank you, Minister, for all of the disturbance that went around you there, spilled glasses and off the script and whatever. Thank you very much. Hope it goes better the next time you're here. For me, anyway. Thank you. So,
that's my fault. Do you want to suspend just briefly, just while we have the turnover in witnesses?
Yeah, can we suspend, please? We now move to agenda item number 3, which is the final panel of this year's NHS-Boards budget scrutiny. And can I welcome to the committee John Matheson, Director of Finance, E-Health and Pharmaceuticals. Welcome. John Conahan, Director of Health, Workforce and Performance. Welcome. And Linda Semple, Head of Efficiency and Productivity Portfolio Office. Welcome to you all. And I think for time and everything, we just go straight to questions. And last week in last week's 7 sessions, there was a discussion around the sustainability of the appropriate efficiency savings target, which has been set about 3%. And I would like to ask you if that is still seen as realistic, and are continued savings on this scale sufficient, or to meet those efficiencies, given some of the evidence that we've heard?
Thank you, Convener.
Yes, thanks.
Perhaps if I might start by just giving a little bit of context in terms of the efficiency programme, and then I'll move on to the efficiency programme for 13-14. We just concluded the financial year 2012-13. The outcome for the financial year is still subject to audit, and that's an important qualification, and that will take place over the next couple of months from a Scottish Government perspective. But the audit of the individual health boards has already taken place, and the final sets of accounts will come in at the end of this week. The position as it stands at the moment, and as I say, audit will take their view on this, is that the resource position has been very much a balanced position. That position has occurred throughout the year, so there have been no surprises during the year. And that balanced position, in the context of a £12 billion overall budget, you're looking at an underspend of 2 or 3 million. So basically 99.97% of the budget has been spent, and that has been achieved in partnership with the staff side colleagues and in partnership with the clinical colleagues throughout the 22 organisations. Efficiency has been a key part in that. The efficiency delivery, as you indicated, Convener, for 12-13 was at the level of 3%, £270 million. That was achieved across a range of areas, including service redesign, which I'll come back to in a moment, prescribing, which I know colleagues who presented to you, attended at committee last week, gave some significant detail on in terms of what was happening in terms of prescribing. So overall, a very positive outturn in terms of 12-13. Moving on to 13-14, we have now signed off all of the financial plans for the individual organisations for 2013-14. The efficiency target again remains at around about 3%, £270 million. We have detailed plans coming in from individual boards in terms of their efficiency proposals. 88% of those are assessed as either low or medium risk. So with a low possibility of any slippage on that. 12% are at a high risk, so they require some further work during the year. But the important message for the committee on that is that the vast proportion, 88%, are at a low to medium risk in terms of that. The efficiency proposals, again, cover the broad range of services. There's a very significant focus, supported by our quality strategy, supported by our 2020 vision on service redesign and service productivity. And that's looking at areas such as the level of day surgery provision, whether that can be increased, looking at the Scottish Patient Safety Programme, the impact that is having on readmission rates, the impact that is having on lengths of stay, the impact that is having on infection rates with the Clostridium difficile reducing by 70% over the last 4 years, MRSA reducing by 74%. So very significant progress there that first of all has an impact in terms of patient safety and how we look after our patients, but also has a very direct impact in terms of efficiency. Prescribing, just a couple of other examples if I may, convener. Prescribing, the efficiency identified in terms of prescribing is just over £60 million of that £270 million. It's a very significant proportion. So the expectation is that prescribing costs, which after staffing is our next biggest area of spend at just over £1 billion on primary care prescribing, 350 million on hospital prescribing, will get a 5% reduction in prescribing costs. And that is set alongside a volume increase of 3%. And a part of that, as you'll have heard last week, has been achieved through the movement from branded to generics in terms of certain drugs, such as one of the major statins, atorvastatin. But it's also been delivered through efficiency programs, and if you want some further detail on that, then Linda Semple on my left will be able to provide a degree of richness on that. So we have a very explicit efficiency program on prescribing, recognising the potential there. So a focus on national therapeutic indicators. So, for example, looking at some of the key cost-effective statins and looking at what proportion of the total statin spend is made up of atorvastatin, simvastatin, pravastatin. Looking for a very high percentage in terms of that. Looking at the generic spend and trying to move all boards up to the upper quartile. So the average for generic prescribing across Scotland is 82.8%. And we're trying to get boards which are slightly below that, up to that level. And there's no clinically justifiable reason why they cannot be up to that level. So we're giving them direct encouragement, direct support through peer support from other health boards in terms of what they have been doing, but also support from within the efficiency unit within Scottish Government. Polypharmacy is the other main area of focus in terms of prescribing. Almost 50% of the population aged 65 and above are on 5 or more medications. 10% are on 10 or more medications. Once you get above 5, clinical evidence is a lot of the additional medications are to deal with the side effects of the first medication. So a very clear focus on polypharmacy and trying to look at that. 80% of that £1 billion on primary care prescriptions is on repeat prescriptions. So the potential there for waste, not a deliberate waste, but waste through people changing medication, etc., and a very explicit focus in trying to reduce the waste that we have. And waste is a cost that just has no clinical benefit because people are not actually taking the medication. So if we can get a focus on that, £800 million of spend in that area. So even a 1% saving is £8 million. So these are the key areas of focus. So the kernel of your question was, is that level of efficiency savings deliverable going forward? The change of approach that we have taken within NHS Scotland, to try and summarise it, is we've moved away from this salami slicing approach of trying just to set the efficiency targets as percentage of budgets, to look at a very explicit target around the areas where we think we can improve our efficiency. And that is very clearly driven by our quality strategy, safe, person-centred, effective care, and also driven by our patient safety programme, which is receiving national acclaim. So when I talk about financial performance now, I talk about quality-driven financial performance. Because if we get the quality right, then delivering the efficiency, delivering the financial numbers is not easy by any means, but it is easier. Because if you want to have a conversation with a clinician about a 3% efficiency target, then you'll have a conversation. It may be a defensive conversation, it may be not the most productive of conversation. But if you go and talk to that same clinician about the quality and the quality of the services and how they can improve them, you'll have a different conversation. And you will get efficiencies out on the back of that.
I suppose what interests me in that, with the board set up, which is difficult enough to get that voice in an individual board or a hospital, how you connect to that with the Scottish Government. How do you get that consistency? Is there a relationship now of when people are presenting efficiencies in and around staffing levels as well as productivity, you're able to highlight problems there or highlight inconsistencies there or between one board and another? Or?
Just a couple of opening comments from me, and I'll invite John John Connigan to make some comments. I think the fact that the patient safety programme is a Scotland-wide programme, so we're doing it across Scotland on a country-wide basis, helps in terms of that consistency of approach that you're looking for there, convener. We also have a central unit within Scottish Government that is there to ensure that best practice is shared across the country. The boards are also very productive in terms of looking at regional approaches. So, for example, in the west of Scotland, the individual boards there have got together on a regional basis to share best practice in terms of how they're taking forward their prescribing agenda.
Who represents the patient safety programme on the individual boards when they're setting budgets, or indeed at your level when you meet health board people? Where does the patient safety programme come into that process?
It may be useful if I describe the framework then of how we approach efficiency and productivity in Scotland, because I think I can then answer your question about where all the various interests lie in this, because it's not just patients. We also need to get a view from staff as well and from health professionals in terms of how we look at efficiency and productivity. So how do we go about it? We recognise that it would be useful in terms of sharing best practice that we establish some kind of framework of support for boards. And in establishing that framework of support for boards, we've now published that. It's available on the Scottish Government website as the Efficiency and Productivity Framework. We refresh it from time to time, and we're currently in the process this year of refreshing it. What that framework does is it lays out three overarching themes. These are support, where we support our workforce to make sure that they're appropriately skilled and trained. We identify what we call enablers, and that's identifying, sharing and sustaining good practice, including benchmarking and the efficient use of technology, including telehealth, and cost reductions. And cost reductions, Mr Matheson here has already referred to some of them, around reducing waste and harm, but also reducing variation. Now, it's quite important that in terms of the pursuit of that framework of support for boards, that it lies very much at local level. The imposition of cost-down, of top-down cost reduction targets on a salami slicing basis, I think history tells us that these don't work if they're imposed. It's much better to have bottom-up ownership. So all of the work within the framework is led by folks from the service. That includes clinicians, it includes who speak on behalf of patient safety, but it also, most importantly, includes staff representatives. And we see the product of that work being displayed each year in what we call our local delivery plans. These come to government, and we see triangulation between the workforce, between the service plans, and between the financial plans. And we assess the risk of these, and Mr Matheson has already referred to the degree of high and low risk that we see in these plans for this year, before we sign these off on behalf of government as being a valid way forward. And if you need some examples of the 8 work streams that are in the framework this year, then Linda Semple can say a bit more about that if you want.
There's no distant, you know, I think, personally I accept the general principle, more money doesn't equal increased quality or better outcomes. That years on, I accept that, but what I'm driving at is about how the Scottish Government monitors those principles. Who monitors and evaluates whether the support mechanisms are of value and are working? Whether people are being enabled or not, or whether we're meeting the costs. What we can probably, if we work back the way, we can monitor quite easily the costs, and we see the cost reductions. But what we less likely to see is the other. Who takes responsibility? Because we've seen in other areas, we don't need to get into them, but we've seen in other areas that health boards, given pressure, don't necessarily ask the right questions within themselves, whether that be sometimes the care of the elderly or waiting lists. Who, you know, if this is a principle, who's ensuring that all of that's working on the ground? Who's monitoring and evaluating and ensuring that that's happening and people are involved in?
So the challenge there is making sure that the proposals coming forward are consistent with the strategic direction of NHS Scotland, as described in the quality strategy, as described in the 2020 vision. So that happens in terms of the clarity of the assessment and interrogation that takes place at individual board levels when they're signing off their financial plans. They're looking at their efficiency programme as a means of delivering that financial balance. So is that consistent with the overall direction? And then when it comes up to Scottish Government for a sign-off by the Chief Executive of NHS Scotland, Director General Derek Feely, then Derek will look for colleagues such as John Connican and myself to give him a view about whether those proposals are consistent with the overall strategic direction of NHS Scotland.
Self-regulating, they're down, and as long as the boards tell you that they're ticking those boxes and saying that's fine with you.
Sorry, just to build on that. So there then also is, I mean, the staff side have a key role in respect of that. The Scottish Partnership Forum play a role in respect of that. The employee directors within individual boards have a key role in terms of that assessment. Your point earlier, Convener, was about where the Scottish Patient Safety Programme sits in that regard. The Scottish Patient Safety Programme isn't a programme that sits to the side of that process. It's very much integrated in that process. And as I referred to earlier, the impact of the Scottish Patient Safety Programme is enabling us to deliver some of those efficiency programmes.
Nanette Millen.
Thank you. I was just wanting to touch, sorry, excuse my voice, touch a little bit on service development. We heard from the boards that a lot are keen to invest in new services. What we haven't really heard is about disinvestment in services that may not be efficient. So what evaluation is done on services that are not efficient, and what proportion of services may not be effective, and is there a move to sort of disinvest in any such proven services?
Might be, excuse me. It might be better if we just take a look at how the budget setting process works locally, and this is very much a bottom-up process as well as inevitably top-down in some respects. But typically, a board has a local management structure which is comprised of clinical directorates to manage, let's say, a large hospital. Those clinical directorates will have delegated budgets which are essentially managed by a lead clinician, a lead nurse, and supported from central finance and perhaps some human resources within the board. And typically they will put together their service plan for that directorate. They will take a look at the historical budgets that have been available, whether or not there's any development monies in the year, and then come to a conclusion about the level of finance that they want to deploy into the various services that they have. Now, where do we get disinvestment? Last year, for the first time, we thought we would supplement our framework by publishing an annual report on efficiency and productivity, and we decided to publish that annual report using case studies. I think I'm right in saying that the 2012 report that we published had 35 or so case studies. Some of these case studies are highlight where we have changed and altered services, where we have disinvested in some things and we have invested in better things that give us better efficiency and productivity. So there's now an evidence base in the process of compilation. We'll do the same again for this year as we build that up, and we expect that that will transmit into across boards as we go through time. And if I can maybe ask Linda to perhaps give us one or two examples from that might be useful to illustrate the point.
Thank you, John. Thank you, Convener and Committee. It's really useful to get the opportunity to tell you some of the good work that's going on. And I think that one of the things that I'm really keen to do, and we're more than happy to share the annual report with you, and the annual report for 12-13, which will be published soon. And that does have, across the two of those reports, around 100 case studies of good practice that boards are doing. Before I share the case studies, can I just give you a wee bit of background in terms of how we engage with the board? The Efficiency Portfolio Office, which is the small team that I'm involved in, we engage with boards in various sorts of ways. We either directly support boards in terms of giving them some expertise around programme management or helping them find the evidence base for things they might want to do. We have a more of a standoff relationship with boards if they are saying we would quite like to do a piece of work. Can you help us come up with some ideas? Can you give us some support around maybe a wee bit of seed corn financing to try and find out if something evaluates well? We then turn those into the case studies that we can say to other boards, Board X has done this piece of work, it's saved a certain amount of money for them, it's improved clinical quality, therefore we think this is something that you might all want to have a look at in terms of whether it's appropriate. I think one of the things that this committee is well aware of, because looking at the conversation you had last week with the Directors of Finance, is that each board is very different in terms of its demographics, its geography, its ability to use telehealth, the makeup of its population generally around its demographics. So not all case studies will be appropriate to all boards. Part of our role is to have that conversation with boards around whether that case study is appropriate for individual boards, and that's what John was saying about a bottom-up approach. We don't impose these case studies on boards. We ask them to consider them and think whether they are appropriate. A couple of really good examples, and again thinking about the kind of things this committee has been interested in. The use of telehealth, teleconsultation. NHS Highland uses that quite widely as a rural board. Dumfries and Galloway uses that. NHS Ayrshire and Arran uses it. Highland use it because of the islands. NHS Ayrshire and Arran uses it with Arran. That allows for a range of both cost savings, improvements in quality, because patients find that they can have a direct conversation with a clinician where before they may be travelling for 8, 9, 10 hours or even overnight, which in itself is a cost to the organisation but is also a personal cost to the patient. And the outcomes of those consultations are evaluated and evaluate very well in terms of both clinical outcomes and in terms of patient experience. Those are the kind of things that we want to say, actually, even if you're an urban board, it might be worth thinking about whether you use telehealth a little more smartly, and a lot of GPs are very interested in that. The ambulance service has been very, very good in coming up with innovative ideas, particularly around things like patient transport. So having a better booking system for patient transport, we know because there have been lots of stories about patients having to be picked up very early in the morning, an ambulance doing a round of picking up a lot of different people, turning up, waiting a few hours for an appointment, and then having to wait again to be taken back. The ambulance service have invested a fair amount of money in smarter booking approaches and better ways of dealing with patient transport. That's something that's specific to the ambulance service, but the use of that service by other boards is enabling both savings and improvements in quality of care across all boards. I particularly like, there's an example, and it's a very small example because it comes from a small board, but if you think about it, if you take that to a larger board, this is the kind of innovation that we want, and it seems pretty obvious, and I think the Scottish Parliament already does it, and that's about paper and print light. There was a time when everybody in every NHS board had a very expensive printer sitting on the end of their desk. Now, a lot of boards have said, this is no longer appropriate, we'll get rid of those. We have a smarter process around printing and paper. Now, NHS Orkney have done that in a kind of big bang approach. Cost them, it saved them a small amount, it's tens of thousands of pounds. But for other boards to do that, it's a significant saving. And all of that money, and I think this is an important point, is reinvested in frontline patient care. We don't expect any of those savings to come back to the centre. And I think that's an important thing to remember. I won't go on about case studies because there are a lot of them, and I'm more than happy to share those more widely with the committee if you're interested.
Just like, if I may just follow up on that in terms of a generic theme, I think in terms of disinvestment, waste, we're disinvesting in waste. And that's the sort of a thrust that you'll find linked through so much of that. I mentioned waste in terms of repeat prescribing, and if you take community nursing is another good example in terms of the amount of time that community nurses spend on admin. So writing out things again. I think the last time I was at committee I gave the example of the DigiPens in the Western Isles, which reduced the admin time that community nurses were spending from 40% down to 20%. And a very significant impact on that. I mean, one of the other areas that we've set ourselves a very challenging target in terms of the reduction in management costs across the NHS in Scotland. And we set a target of 25% reduction by March 2015. And we're very much on target for that. By March 2012, we'd reduce by 16%. And we'll get a further update in a couple of months' time. So waste in terms of the use of staff resource, in terms of the way that we procure, and looking at how we can procure more effectively. We have a national organisation for the procurement of supplies and services, and we're looking now to extend that service to other parts of the public sector.
Can I just add one very quick thing to that, Convener? Of course, disinvestment in services always has an impact on clinical services. And perhaps one final example on this is the move to one-stop outpatient clinics. Now, that's you could in many ways see that a disinvestment in lots of different clinics, but from the patient's perspective, coming once to have your x-ray, have your bloods, see the allied health professional, and then see the doctor is a significant benefit. And Scotland has significantly increased the number of one-stop clinics that it has over the years. And perhaps another prime example is a move from inpatient services to day surgery services as clinical services change with new techniques and the introduction of keyhole surgery some years ago. So all of that, you could say, is the disinvestment in one service, but an enhancement in another service with a better deal for patients.
Sorry, very briefly. Linda Semple mentioned the use of telehealth, telecare, but using IT more effectively is another challenge for us. And in Grampian, they have a project called the No Delay Project. And one of the things they've found out is when you go to a consultant for an assessment, you're sometimes given bad news, and sometimes it's difficult to take that on board. So what they do, or they're proposing to do in Grampian, is to send out a digital postcard so people who have attended the consultation will get this email that summarises what was said to them. If they have been identified as having a particular condition, say diabetes, there'll be a link to Diabetes UK, there'll be a link to eating advice, dietary advice, etc. So they'll get a sort of holistic message about what their condition is and what they can do about self-managing it.
Yes, I've seen a presentation on that, and I have to say it was very impressive. So thanks for that information. In more material terms, I mean, we know that there's a significant backlog of maintenance in a number of health boards. Do you think that is there an appropriate balance between investment in new facilities and in maintaining existing facilities? How's the balance there?
You're right to highlight that point. What we did a couple of years ago is we identified the total position in terms of backlog maintenance, and the figure was just over £1 billion. The last update we've had on that, it has reduced by £60 million to 948 million. That is made up of all backlog maintenance, so low, medium, significant, high. The If one focuses on the significant and high component of that, then that makes up about 500 million of that. And that's reduced to about 450 million in the latest assessment. Deliberately, as part of the last spending review, we transferred £320 million of resource money across to capital over the period of the spending review to specifically focus on backlog maintenance. And over the next 5 years, we think that our investment in formula capital, plus the disposal of assets, will enable us to cover the high and significant component of that backlog maintenance challenge. And to give one specific example, because the figures do look, they are, like even to a finance director, £1 billion is a lot of money. But if you look at a board like Dumfries and Galloway, their backlog maintenance gross position, all their backlog maintenance, low up to significant, was £63 million. Dumfries and Galloway Royal Infirmary, the new build of Dumfries and Galloway Royal Infirmary, will reduce that by about £40 million. And the proposed plan for investment in backlog maintenance plus disposal of assets will deal with the balance, and you'll be left with a very low single figure at the result at the end of that. So yes, there is a challenge there, but the key that we have with our capital investment, it goes back to one of my previous points, is to make sure that the capital investment is driven by our clinical strategy. And the investment areas that we are looking at, the New South Glasgow development, £842 million, which is on time and on budget. The investments in terms of a new sick children's in Edinburgh, the emergency care centre in Aberdeen, these are all investments that are driven by our clinical strategy and our quality strategy.
Some boards must be deferring expenditure on certain things. I mean, do you see any particular outcomes from that, either good or bad?
Capital is extremely tight. There's no getting away from that. There was a 30+% reduction in the overall Scottish Government budget. We have to recognise our legal commitments. I've mentioned South Glasgow, and there's a number of others in train. But notwithstanding that, the formula capital allocation that is given for backlog maintenance is increasing year on year. And that's why and that's been as a result of the transfer from the resource to capital of £320 million. So at a local level, there's a very clear process in terms of property and asset management that prioritises the areas that they do need to focus on in terms of meeting their statutory requirements and meeting the requirements of clinical services. And at the end of the 5-year period, we are confident that we will have dealt with the high and significant backlog maintenance issues.
So that strategy is guided by government?
It's guided by the clinical direction, the quality strategy of the NHS Scotland. The local decision-making in terms of prioritisation is made quite rightly at a local level involving clinical colleagues.
Thank you, Convener.
Thanks. Just some clarification on the maintenance backlog. Is high the highest point of risk? Is there a higher level? Is it a critical list? Higher, low?
Significant is the top, and then high, and then medium, then low.
Could you tell me how significant, as I understand it, means impacting onto services and that patient experience? A theatre closing down, a leaky pipe. Why didn't you mention significant when you referred to the risk and only mention high and when you break down your...
Sorry, apologies, I thought I had said high and significant.
No, you didn't say significant. Could you give us the figures with significant included and how much the bill for significant risk is at this point in time?
I don't have the split between high and significant. I can give you that. What I said was that high and significant together, so apologies, what I thought I said was that high and significant together came to around about £500 million.
Okay,
if it didn't make that clear, apologies.
I didn't hear you saying significant. But is it about a 50-50 split then, in terms of high, significant, 40-50 split?
I don't have the split in my head. I will bring the split to the committee.
You know, why? You know, getting back to my initial point about the evaluation of effective decision-making, which was the point I was trying to make earlier, how can we describe anything other than poor management and lack of efficiency in decision-making, that we came to a situation when we had a a backlog maintenance in our hospital estates to the level that we are now. How did that happen without you and your team noticing?
Comments on that. One, that position didn't happen overnight. What we did a couple of years ago is we actually identified that position and they quantified it for the first time. So, and I think it's very helpful to have that degree of quantification. In fact, it's a big figure, a small figure. It is a big figure. But the fact we've actually identified it, I think, is positive. There was and there is a backlog maintenance programme going on that is dealing with the priority areas. So this is an ongoing issue. I think what happened 2 years ago is we actually asked the estates officers to go around and actually identify the total position. And that's where the figure of £1 billion came from.
I accept making any political point on this government that this did arise over a period of time. What I'm trying to get at is how did we get to a situation with management in place, left to make these decisions in individual boards, your oversight that brought us to a state where we have that bill of a backlog maintenance. Why can that happen? You know, if it can happen there, in backlog and maintenance, how or why are you confident that it's not happening in other areas if this self-regulation is going on? Are they telling you anything? You know, did we believe everything that they said about backlog maintenance and it wasn't an issue? Nobody noticed. Nobody was asking any questions. Why isn't that? Why weren't people asking questions about the maintenance of the state in our hospitals? Why was that happening?
But that was precisely why we have the new capital programme going forward. So that's precisely why we were building the New South Glasgow to replace the Victoria. That's precisely why we're putting the new emergency care centre into Aberdeen. That's precisely why we were building a range of health centres across Scotland. So that programme has been in hand for a number of years, and a number of these projects are now coming through to fruition. A number of these projects are working their way down the pipeline. So this is an ongoing process. I think the difference is that we have now identified the scale of the position.
You've asked the question for the first time in terms of the...
I think previously people had a part of the picture. We've asked for the total picture.
You wanted to...
Yeah, I'm just reflecting, Convener, on my experience some years ago now as Chief Executive in several boards about backlog maintenance. And I think when you get the figures, it would be useful to understand the breakdown of the significant element of that in relation to what proportion of the significant element is directly impacting on clinical services, what proportion is calculated on redundant buildings that are still there on the books, so to speak, but are up for disposal, because they're part of that figure, and how much is in non-essential areas that we can leave and with good judgment leave because they don't pose a risk. So in terms of a risk assessment of this, I think it's quite clear that local boards have a responsibility, and through their own local board investment plans, where they've got a significant degree of discretion about how they deploy that backlog maintenance fund that they have, you'll probably find that adequate risk assessment takes place, which is scrutinised not just by internal audit, but by external audit as well. So I think the breakdown that you get will be important to perhaps put all of this in context.
I look forward to you. I posed the question in the context of significant and high. I understand the difference between a lick of paint and a theatre being closed down for a weekend. I understand the difference. But that in itself was not what was put. I was looking for the oversight and the good management that should have been in place to prevent the scale of that situation happening. I was just looking for oversight. Drew Smith, followed by Richard Lyle.
Thank you, Convener. Last week with the financial directors, we had a discussion around brokerage, and you would expect this, but those boards who were unable to manage their budgets and relied on loans to break even, were quite positive about the brokerage experience and felt it had been useful. I wonder if you just give us an indication of whether you expect to be giving loans to boards again in this year, or whether that's a problem that is resolved. And do you accept some of what the boards were saying, that brokerage is a flexibility mechanism that's useful and desirable, or do you take the view that it simply shouldn't happen?
Thank you for the question. Again, a little bit of context. Brokerage is not given lightly to individual boards. It's predicated on me having reassurance from the boards that the requirement, the need for brokerage, is predicated on some temporary financial challenge that they have, and they need some support to get around that challenge. One of the issues that we have is we have the artificiality of financial years. So if you're trying to do medium to long-term planning, which is where our focus is, then the artificiality of 12-month periods and to hit particular financial targets every 12 months is to an extent unhelpful. And it might be better to have some sort of rolling statutory target over a 3-year period. So if you take, for example, Forth Valley and Fife, two boards which received brokerage recently, they had temporary financial challenges around the move into new hospitals, and that required some brokerage. I got reassurance, and it was very challenging in checking that reassurance, that they had robust financial plans going forward, and this was a temporary situation. And also that they had the ability and had built into their financial plans the ability to repay that brokerage. There's an issue about being fair to other boards that do not get brokerage. So there's an issue about fairness and equity in terms of the position. Your initial point was, do I expect any boards to need brokerage in terms of 2013-14? We have signed off the financial plans of all of the boards. There's one board that we're in some discussions around just now, but at the moment there are no plans to give brokerage to any of the 22 boards. We have also an expectation that's built into the financial plans that the expected repayment of brokerage will come back to as expected in terms of 2013-14. I think the brokerage for most of the boards will be completely repaid by 2015-16. The flip side of brokerage, of course, is boards looking to return money to us. And there were two examples of that last year. One was Dumfries and Galloway, which was looking to bank some money with us to enable them to cover the double running cost of Dumfries and Galloway Royal Infirmary when it opens. And also, linking back, convener, to the previous point, the Lanarkshire returned £4 million to us in 12-13, which they're going to use to take forward backlog maintenance initiatives at Monklands Hospital in the current financial year.
So, I'm hearing from you there that you would want to dissuade any financial director that viewed brokerage as being a flexibility mechanism. It should be exceptional and in a sense fixing a problem. In relation to the money coming back to the centre as well as the money going out, what is the balance between the two?
In 13-14, we don't have any money coming back in the moment because no boards have indicated at this point in the financial year that they want to return any money to us. In terms of 12-13, we had £8 million coming in, and the brokerage support that went out was, say, £14 million.
Thank you very much. In terms of the issues around double running, shouldn't boards be planning for double running anyway if they're replacing a service, and presumably this is something that's going to continue? Are we now in a situation where wherever you redesign a service and put in place a new service, and that might result in a level of double running, you just ask the Scottish Government to pick up the tab for you?
I think for the two boards that I've mentioned, and also for Dumfries and Galloway preparing for it, the significance of the move of clinical services from Stirling and Falkirk Royal Infirmary into Larbert and within the Victorian in Fife meant that double running costs was anticipated. Forth Valley had actually anticipated some element of the double running costs, and it was only a marginal movement over and above that they looked to Scottish Government to support. So they had already used some of the property receipts from the sale of Bellstack Hospital to fund their initial anticipated cost and double running costs. They moved slightly, and it was that additional element that they came to Scottish Government for support on.
It seems quite surprising that you build a new hospital, you know you've got the hospital you've got at the moment, you know, to run. Fair enough, you might want to run down that service, but why would you be surprised by a double running cost? And I suppose the example I would have would be in Glasgow, where we've got, as you say, a very significant investment in a new hospital and presumably a significant amount of double running that will be involved in the initial periods of setting up the new South Glasgow hospitals. You would expect that Greater Glasgow and Clyde can manage all of that from within their the budgets that will be provided to them.
And those boards within their financial plans had anticipated double running costs, as Dumfries and Galloway have, but it was the marginal movement that they came back to us for support on.
So in Glasgow's case, for example, you wouldn't envisage there being a problem around the South Glasgow's?
They have not approached us, and we're not expecting any approach.
Okay, thank you. One of the other issues that we touched on last week was around, well, I'll maybe just ask two things together for brevity, convener, but one is around the unidentified efficiencies and the scale of that within both boards and I think the special boards as well. Could you maybe just say a word about how you deal with that as departments when these bodies are coming back to you with unidentified savings? What checks do you then want to make? And also if you could say something particularly around some of the high-risk efficiencies that boards identified. Dumfries and Galloway last week told us that 25% of the savings, or around a quarter of the savings, that they plan to make were defined by themselves as being high risk.
The couple of comments in respect of that. One, just dealing with the special boards, first of all. Linda Semple indicated earlier that efficiency savings within territorial boards are retained by those boards, and that is absolutely the case. For 4 of the special boards, any efficiency savings that they identify is treated in exactly the same way. It's retained by the board, and that's the ambulance service, the Golden National Waiting Time Centre, the State Hospital at Carstairs. For the other boards, we set an efficiency savings target, and we withdraw that target back to the centre. And in 2013-14, we're expecting £9 million to come back from those 4 special boards. That £9 million will be used for Pan-Scotland initiatives. So, for example, in 13-14, we will use that to support the funding of the Rare Medicines Fund and also support the funding of the cost of new vaccines for shingles and the seasonal flu. So that is the approach that we take there. In terms of unidentified savings, when we get the efficiency savings response in, we do challenge the actual assessment in terms of unidentified high, medium, low to make sure that we have some consistency across Scotland, because it is subjective to an extent, and some people may take a very prudent view in terms of how they're positioning their savings. As I said, across NHS Scotland at the moment, 88% of the savings are in the medium to low category. The unidentified element is about 4% across Scotland. So of that remaining 12%, 8% is high and 4% is unidentified. Now 4% of 300 or million or thereabouts is still £12 million. So it's still a significant sum of money. So we will stay very close to those boards, ensuring that they have the pace and impetus in terms of turning the high-risk savings into medium-low to give some degree of increased assurance around deliverability, and also that they have moved their unidentified into specific schemes. We would also look, as we move through the year, and we have a mid-year review as well as an annual review for those individual boards, and we will have a month-to-month contact with the certain boards. We would look to them for them to be developing reserve projects if we feel that there is a significant risk that they're not making their anticipated progress in terms of either firming up on the high-risk ones or identifying precise projects for the unidentified. So it is an iterative progress, a process that has already started. You mentioned specifically Dumfries and Galloway. We would look at their pedigree of performance last year in terms of at the start of the year how much was unidentified, what was the performance at the end of the year. So are they taking a prudent position? And we would have detailed discussions with them in terms of how they're going to identify that 25%. The final point I would make on that is that within the individual boards, there will always be non-recurring flexibility that boards will use to support. We do take a view about what proportion of the efficiency savings is made up of non-recurring projects to make sure that that does not become too high.
Just two final things, Convener. I mean, I suppose first of all on that point, I mean, because that's one of the things that Audit Scotland have identified as being very concerning. So where is, in terms of taking a view about the level of savings that should be paid for out of non-recurring funding, what is that level? And secondly, I suppose going back to the first point, and this is about the relationship between unidentified savings and then savings that are then identified to be high risk, what is the relationship between the two? Because I suppose you would want to know the extent to which a saving that is a percentage of savings that are initially suggested to be unidentified, then at a later point, perhaps at the mid-year review, turn out to be high risk, and that boards are, perhaps unwilling to say that something is high risk, or whether they simply have a large amount of unidentified savings that are going to come from switching printers off and the likes.
It's a powerful point. We have a very clear and explicit focus on boards' reliance on non-recurring support. The Audit Scotland have also picked this up. The test I've had from my experience as a finance director is round about the 0.5%. So once you get above the 0.5% in terms of reliance on the non-recurring support, then bells start to ring. The position within NHS Scotland in terms of 11-12 was the reliance on non-recurring support across all of the boards was £31 million in 11-12. In the last financial year just closed, that had reduced from £31 million down to £21 million. And the indication in terms of 13-14 from the financial plans that we've just signed off is that there will be no reliance on non-recurrent support across NHS Scotland.
Could you maybe just say a word or two just about that relationship between unidentified and high risk as well, and how you monitor what moves between those two?
We have a very clear focus on that and a very explicit focus on that. So, I mean, ideally, we would want the financial plans to come in terms of them all sitting at medium-low. But in terms of this position, 3 months into the financial year, to have 88%, and that 88% was in the original financial plans. So we give boards a bit of breathing space at this time in the year to finish off the annual accounts. And although they produce monthly statements internally, we don't get the first monthly statements from the boards until the beginning of July for the 3 months to the end of June. So in 2-3 weeks' time, we'll have an up-to-date indication in terms of where they are and where that proportion has gone from the 4-5% in terms of unidentified. We look for that to come down significantly, but we will then test that. If it hasn't moved, then we will have some very direct conversations with those individual boards.
Do you have a sense of what the relationship has been in previous years?
The figure of 88% in terms of medium-low is higher than in previous years. The starting point for 12-13 in terms of the efficiency savings was 73%. Medium-low, so that's gone up to 88%. So there's a much smaller proportion at high and unidentified than there was in previous years.
Thank you. Richard Lyle.
Good morning. I've got
Bob
actually quite a few questions also, but can I go back to the point the convener made in regards to buildings and building maintenance? Would you agree that some of the buildings that were built back in the 60s and 70s now were the wrong design, and we're now seeing the problem with that now as we're in 2013? And also, would you agree that some of the buildings built away back in the 1900s actually have survived better, but we're now replacing them with newer hospitals?
I would agree with both those statements. The issue about buildings and building design, we could have a detailed discussion around the single rooms and the pluses and minuses of single rooms. But our policy is for single-roomed accommodation, and that is how hospitals such as the new Royal Victoria, located within the Western General, have been designed. The building design, we work very closely with the architectural colleagues and also with clinical colleagues, because the issue about building design is it needs to be designed to make it effective and efficient from a clinical perspective. So that level of clinical engagement in buildings such as the new South Glasgow is absolutely essential. And that has been very close and very direct in terms of their involvement directly in the design of the buildings and the layout. And even simple things, if you go back to some of the buildings of the 1960s, then you had the common corridors for patients and for public, which is wholly inappropriate. And that has now stopped in terms of current designs.
Right, can I turn to my main question would be, and it will become apparent shortly why I'm asking this. Could you remind the committee how much the total overall health spend is in Scotland?
The total health spend is just over £12 billion. It's increased by just over £1 billion in this spending review, and the increase in 13-14 overall is 3.3% increase for territorial boards in 13-14 and 3.1% in 14-15.
Oh, 3.3%. What's the current rate of inflation?
The current rate of inflation in terms of the gross GDP deflator is 2.3% against that 3.3%. So that's a 1% real increase.
Right. The real reason for asking that question was I note that the earmarked funding, which is basically specific funding allocated, ring-fenced. Over the last number of years, the government have reduced, in particular to ring-fencing, have reduced ring-fencing within councils. Councils are more freer now to spend the money which has been given to them, so it's no longer ring-fenced. Why are we still allocating 12% of ring-fenced or ensuring that boards are ring-fenced by 12% within their budgets? Would we not be better to free that up? I noticed that 12% ring-fencing is for such as projects for alcohol and drug treatment programmes. Do you think 12% is too high?
A couple of comments on that. Those figures and the precise budgets were identified as part of the original budget at the start of the spending review. Over the last number of years, I have promoted the idea of not giving out individual allocations and sort of micromanaging around basically inputs. And I've looked to develop the principle of bundling some of these allocations and giving colleagues and boards money around generic themes such as primary care, such as mental health, and basically giving them the autonomy and to spend the money as is appropriate. What is essential in that, though, is that they still continue to deliver the outcomes and outputs. So if you take alcohol as an example, then they need to deliver on their brief interventions, which is the key heat target in terms of alcohol. How they do it, I think, should be an element for local discretion. So rather than giving them a pot of money and then asking they've appointed a part-time alcohol nurse, I'm not concerned about that. That's an input. What I'm concerned about is the service provision that has resulted from that. Within that, sorry, final point though, within that 12% is also some of the major primary care practitioner contracts, GP contract, dental contract, ophthalmic, and that is a significant proportion of that. But the principle that you've identified there, I'm totally wedded to, in terms of not micromanaging the service, giving them the responsibility to deliver, but having clear expectations in terms of outcomes and outputs. And I would look to see that model extended into the next spending review.
I'm very happy to hear you say that, because at the end of the day, within councils, it actually has promoted and helped councils more that ring fencing has been taken off and they're allowed to manage the money and deliver the outcomes which are agreed. I'm not suggesting that we take off the shackles and don't let them do the things that we want them to do, but I know that they are doing them. But basically, do you have a view? Just two questions left, Convener. Do you have a view that the appropriate level of this earmark funding is correct, or do I take it you want to you want to ensure that they have more autonomy and can do more with this money?
I would welcome the opportunity for boards to be given as much autonomy as possible. We don't hold back contingency sums at the centre. We give out as much as possible at the very start of the year. And even the year-marked allocations, we give them out at the earliest possible point in the year. So a significant proportion of that 12% that you've identified will, 3 months into the year, be out with boards at this particular point in time. So the thrust of your principle, I'm totally with.
So I take it, my last question is, I take it you are very happy to look at some way to change this, to enthuse boards more to use this money for the projects we want them to do, but also to use it better.
It's a process I've already got in hand, and I'm keen to see accelerate.
Thank you very much.
To that, which is that I think it's worth reiterating that the work we're doing with boards, supporting them to deliver their efficiency savings, is freeing up resources that they can then choose how they spend those resources. And I think the spread of projects that we're doing with boards, which is enabling them to have a sustainable approach to how they deliver their efficiencies in the long run, means that they will be able to reinvest that money in the things they want to do and that their citizens say that they would like them to do.
Very happy to hear.
I think there was an interesting area, and it links in with some of the other issues, of course, that we're dealing with as a committee, with inequalities and preventative spending, and which we are interested in. And it might be useful, and I think we picked some of this up at our parliamentary away day. We had a committee meeting in Stirling when we were discussing round the table. We'll send you a copy of that session. I thought it was interesting that the link that the good meaning in terms of, I don't criticise it at all, but without actually looking deeply into it, but that focus on particular problems in communities and targeting particular problems creates sometimes for practitioners a bit of inflexibility and in terms of how they see alcohol and drugs, not simply as an issue on its own. So I thought there were some interesting insights in that session that you may want to consider, given that you're rolling that out. We say no more than that, but I thought it was from practitioners some interesting, insights to how decisions made at your level can impact and sometimes distort, not intentionally, but by creating some inflexibility in and around these issues. So we'll send you that for your information.
Thank you. Convener, you mentioned just a brief one. You mentioned the preventative agenda there, and we've spoken about patient safety, which is very much aligned to that. But one of the other areas that we're extremely excited about, and it picks up with the previous comments about connectivity with the local authority side, is the Early Years Collaborative. And that has got some tremendous enthusiasm building up through a number of national events, with the practitioners getting together and looking at how they can improve the experience of the parents and their children, and looking at supporting children to reach developmental milestones at 30 months and developmental milestones when they leave nursery, and trying to reduce the proportion, which currently sits at around about 30% of Scottish children who do not reach identified developmental milestones at those particular time thresholds, and trying to reduce that 30% figure by 50%, so halving it by 2.5 years, and then reducing it to 2/3 by the time they leave nursery. So that, alongside the patient safety programme, is something that's been taken across and taken out on a nationwide basis, and very closely involving local authority colleagues as well. So that's a good example, I think, of the preventative agenda that we're trying to move forward.
Yeah, we have been looking at, as you know, we haven't concluded our report, but I think, and we all accept that health has got a role in this. But in terms of cross government, there are a number of budgets that could be contributing to that benefit. I think is a general point that we've been making. But it's it's interesting to hear you say so. Bob Doris.
Thank you, Convener. I want to come back a little bit for a couple of very specific reasons in relation to the NHS estate and the review of the condition of the assets of the NHS estate and the backlog therein. it always feels a little bit like Groundhog Day sometimes for me on this committee, because I also sit in the Public Audit Committee, and we've looked in some detail in relation to this in the Public Audit Committee, and I think this committee might want to review some of the correspondence between the Cabinet Secretary and the Public Audit Committee in terms of some of the reassurances and the management of that backlog. I want you to get a little bit more information, very briefly, hopefully, if that's okay, in terms of the situation before this significant estate review was done for right across the NHS. So just remind me of the year that the review was done and what would have happened, say, 5 years ago or 10 years ago if the national government wanted to just have a snapshot of where the building conditions and the facilities conditions was within the NHS in Scotland.
The estates review was carried out in 2011, and that's when the figure of £1 billion was identified. If you go back 5 years beyond that, then people would have been aware of bits of the jigsaw. So probably some of the major areas that were causing a particular problem in that board at that particular point in time, and then perhaps some central money might have gone out to deal with that problem. What we've done on the capital side is we have identified the capital spend for individual major projects such as South Glasgow, but we've also given the balance basically out to boards on a formulaic basis to allow them to do their local prioritisation. We've also said to boards that in terms of the capital disposal, that they will keep the profit on any disposal of any capital assets, and that can be used for local prioritisation. And we'd expect to be engaged with them in terms of what they were doing in terms of that prioritisation. But we'd expect backlog maintenance and high and significant risk backlog maintenance to be a major factor in respect of that.
Yeah, I suppose what I was trying to draw attention to, Mr Matheson, is the fact that when you use a figure, when a figure such as 1 billion is used, it can create alarm bells. But if what's actually happening is we're identifying the real figure for the first time, the positive aspect of that, you have to quantify the scale of perhaps underinvestment over a generation in some parts of the NHS to then come to the solution. So what I want to get towards is, first of all, in terms of that backlog, what element of it will be, for example, when you mentioned significant and high risk repair needs in terms of the backlog, would that include services that will be replaced anyway by the new Southern General? In North Glasgow, there's a new health centre in Postle Park going to open in a few months. Will some of those liabilities disappear off the balance sheet once that reopens, once that new health centre reopens? Or in Maryhill and Woodside, where they're about to commence new health centres in North Glasgow, what is the extent to which that 1 billion figure will reduce because of works already in the pipeline? I think that would be quite helpful for the committee.
Well, let me just try and just go over the figures then again. So the gross figure was £1 billion at the time of the initial survey. 1 year on, recognising investment that took place in that period, it had reduced to 950. That is total position. That is low, medium, high, significant. Focusing on high and significant would make up just under 500 million of that. And once you allow for the disposals planned, etc., then that brings that down to just under 400 million. There are plans in place, there's formula capital identified, partly through resource to a capital transfer, to deal with that residual element over the next 5 years. An example I tried to give to highlight that was the Dumfries and Galloway one. When you look at their gross position, just over £60 million of that total £1 billion figure is, say, the gross position within Dumfries and Galloway. But when you recognise then the fact that they're going to move out of the existing Dumfries and Galloway Royal Infirmary with its, say, high significant component, then that move on its own will reduce their backlog maintenance from just over £60 million to just over £20 million. So it will reduce it by £40 million. And that was intended to be an example just to show the scale of the current investment plans and the impact that will have on backlog maintenance, but also the fact that we have formula capital identified within the capital programme to deal with the residual element. The one piece of outstanding information, I apologise to the committee, that I can't give you just now, is the split between high and significant. And I'll come back to the committee on that.
Now, it's not to give you an easy ride to show a downward trend in these figures. I've got another reason for asking this. It does sound positive, but what the figure I've written down just now is that £400 million will be the backlog for high and significant once all these other factors have been taken into account, as you've just said. You then said there's a 5-year plan to tackle that £400 million backlog. So this is an annual scrutiny that this committee does of the NHS. So this time next year, whether it's myself and Mr McNeill or whoever on this committee, this time next year, is there a target for what the £400 million will be? £350 million, £320 million? Or is it not as straightforward as that? Because what I want to make sure is when you come back to the committee this time next year, we can have a degree, we've got a benchmark from which to scrutinise the progress being made by the NHS.
To provide that. I didn't think I was getting an easy ride on this subject, by the way.
Right. So can you provide that just now?
I'm happy to. I can't provide it just now, but I'll bring that to the committee.
It does. So the figures do exist.
Yes.
Right. I think that
we have a formula capital identified which is increasing over the period of the spending review. It's in excess of £130 million per annum, and that formula capital allocation is prioritised on backlog maintenance.
Right. Okay. So. And
that's why I have confidence over the next 5 years that figure will be dealt with. The residual.
That's fine. So when this committee asks the question again next year, you'll be able to assert, well, that £400 million is now less than that. The figure is whatever it is, and that's because of X, Y, and Z has happened. Yes. And if that hasn't happened, then there'll be questions, obviously, we'll need to look at then. But you're confident that things are on track?
Very confident.
Okay. Now, very briefly on efficiency savings. I know that, again, there's been some discussions around that already, but again, just for clarity, in terms of the 3% efficiency savings target that obviously NHS-Boards get to keep, the position of NHS Education was a bit different in evidence to committee last week, where they were being judged on efficiency savings of 3% across the board, whereas much of what they do is directly corresponds to direct training interventions they must do to meet their statutory obligations as an NHS board. And it was suggested by NHS Education that there might be a more appropriate way to report how they are meeting efficiency savings, which takes into account the parts of their business, if you like, that you can't do a service redesign around to get more efficiency, and the bits where you can do a service redesign to get more efficiency because they're in quite a unique position. Has any consideration been given to that?
When you look at National Education Scotland, their overall efficiency percentage comes out at 0.8%, which seems very low. The reason for that is a significant proportion of their budget is actually protected because it pays for junior doctors and other clinical staff. So their efficiency percentage, which is a 5% target, is only focused on a small proportion of their budget. So presentationally, we can look at the position of that. But they have the same efficiency target as do the other special boards, such as Health Scotland, such as NHS-24, such as, say, Health Improvement Scotland.
And you mentioned the expression presentationally, but just in terms of the hard facts of the matter, it's not even presentational. Is it just a bit unfair on that particular special board to have their figures presented as 0.8% efficiency saving, when actually if you look at the areas which would be subject to that kind of efficiency savings, it would be a different sum and it would probably show greater efficiencies than 0.8%. So not even just in terms of how it's presented, but in terms of what the rules are around that. Do you think that's something officials and the Scottish Government might consider changing?
National Education Scotland are clear about what their target is. They're clear about what components of their budget their target is. So basically their efficiency is focused on their use of property, It's focused on their administrative infrastructure areas such as that. And that's why National Education Scotland are looking at reducing their utilisation of buildings and driving efficiencies through that. But I'll have a discussion with them around the presentational side. But they've obviously specifically raised that last week.
It genuinely might be worth just having a look over the official report in terms of the evidence they gave, that they're up for efficiency savings, any area of their business and service where they can drive efficiencies and do better and get a bigger bang for the buck. They're up for it. They want that figure to be as high as possible, but there's a part of their business that it seems, in an accounting sense anyway, doesn't quite reflect the efficiency savings they're actually making. So I welcome your commitment to have a look at that and discuss it with them.
I think to be fair, all four of the special boards, including NSS, who have had a differential approach in terms of efficiency savings for their non-patient services, with the savings being withdrawn, have responded very positively to that challenge.
Thank you.
Back to that backlog again, I think my question was not what we're doing now, is why it took so long to do that now, and it links with the management and the oversight. There was a point in time in the last decade we were awash with money in the National Health Service. Why are we at a time of reducing budgets, I suppose I'm on about, is that did management let us get to a situation where we have got to face that now in a time where the budgets are tighter. So it was the managerial process that I'm focusing on. There are people who are around this table who run businesses who know that the maintenance of their assets and their property has got to be dealt with on a planned basis. And it seemed that during a period of time, over different governments, there seemed to be a lack of oversight and poor managerial decisions at a local level that allowed this backlog to build up. That at a time when there's less money, £400 million got to be found. So it was focused on the management. Can I continue on the management? Because earlier you said that it was a virtue that we'd set the target of cutting management by 25% and we're making good progress there. How does that fit in? Is that? I know that's popular among probably us right about the table. Oh, you sack the managers. It's like, but is that the wisest decision to be taking when we have great challenges in innovation, changing the service, preventative agenda, all of that is happening in there? Is it the widest decision that we are cutting back in management levels and management capacity and thinking? Is that something?
I'll maybe take that question if I could, convener. Of course, remember that this is over a timescale. It's over a 3 and 4 year period. So I think we need to look at all of our managerial structures. We obviously need to make sure that we have got good and adequate risk assessment of that. If we can do something in terms of combining, let's say, directorates, so we have got less managerial support, but we can still do the business practically, then that's important. In fact, if you look at the 2012 annual report, there's a case study in here somewhere of one board that previously operated with 5 directorates, moving to 2, and that automatically takes out a layer of management. The other thing I think we must also recognise is that across boards, and we haven't mentioned this much today, there is a significant move to shared services. We've seen that significantly in finance. Mr Matheson there will be able to tell you a lot more about what's been achieved over the years on that, but we can't rest on that. So shared services and restructuring also need to be part of this, but I do recognise the point about good risk management and making sure that we have got enough and we have leadership locally to be able to move things forward.
Yeah. And so it's not simply a cost-reducing exercise? Or?
It certainly is a cost-reducing exercise in the sense that we want to see a financial return for this, but we also need to balance that out against what we need to achieve in things like quality and the leadership of our workforce. So it's a careful risk assessment of what boards can do, locally if there's an opportunity there to do things on a much smarter basis by sharing services or by having less managerial levels in an organisation, then we should be pursuing that.
Yeah, I can see some of that, but how do you achieve the best results to ensure that we, the managers or the leadership that provided those 100 good examples, are they the people that are leaving?
Well,
some of the people who brought forward 100 of those good examples in those teams, are they leaving because they are valued elsewhere?
Well, of course, in the NHS we have no redundancy, no compulsory redundancy policy. So naturally, some of the folks that have been involved in these schemes over the years will cycle through, will leave the organisation, and then it will be a careful assessment as to whether or not these folks should be replaced. And that careful assessment takes place at local level.
So, Convener, that risk assessment is very important. So all proposals are not accepted in terms of a management change because of the assessment in terms of the impact on the organisation. John Connican mentioned the financial shared services. So we were spending £50 million across NHS Scotland on the backroom support for financial services. We have reduced that to date through a shared services approach by £11 million. So that is a 22% reduction or thereabouts in terms of that. And that has been done working very closely with the partnership colleagues.
But the people who were delivering that service are still employed by the National Health Service.
Yes, but
So the people who used to, somebody else is doing it now, but the people who used to do it are still in the health service. What are they doing?
But if you take financial shared services as an example, that saving of the £11 million, 22%, has been achieved through more efficient use of technology. So moving to a single financial system across NHS Scotland rather than having individual financial systems, using a technology to process invoices more effectively, etc., etc., etc.
So are you on target for the savings you expected to get? But I think we're next to the creche. They're probably listening to this committee meeting. But so in terms of the expected return for the 25% cut in management, are we on target for that?
On target, yes. There was a 16.1% reduction at March 2012.
And we're achieving all of the appropriate management clean out on the basis that the 16% cut, does that equate with the 25%? Are those people leaving the organ? 16% of that total. What was that total in terms of numbers rather than percentages? How many managers and managerial positions did you expect to flush out?
In that category, we have about 1,000 managers.
People.
1,000 people, of which about 250 is that 25%, give or take, roughly.
I think that puts it in perspective, but the wider issue about...
We have 153,000 plus employees in the NHS, but about 1,000 senior managers and 250 of them will depart.
You mentioned earlier just on local authorities and this, another issue that we're going to be looking at as a committee. And do you see anything from the figures that give you any concern in terms of the resource transfer from some health boards, the other health boards, in terms of good practice? We see resource transfer in some health boards to local authorities, which is quite significant. In other areas, it's not significant at all. Does that give you any concerns, or is it just... Is it a matter of practice or interpretation? When we're encouraging, a lot of that. Do any of these headline figures give you any concerns? And have you had any discussions with these boards who are lagging behind in terms of their resource transfer?
I think in terms of resource transfer, there's a couple of points there. There is always a detailed annual discussion around the uplift to be given in terms of resource transfer. We work very closely with boards and indeed with local authority colleagues to make sure that we have clarity around what the resource transfer is delivering. But the second point, which I think is the more powerful point, is the resource transfer discussion debate will now become incorporated within the health and social care integration debate. and that the bill has now been laid before Parliament at the end of May, and we're in very detailed discussions with COSLA and with local authority colleagues. We've got a meeting this evening with the local authority colleagues on this very subject about ensuring that we progress health and social care integration in terms of the integration of services. And that will also, the bill also affords us the opportunity to look at our shared service organisation, NSS, and how they could potentially provide legal and other services to local authorities and other aspects of the public sector. So it goes beyond health and social care integration. But I think the resource transfer discussion will now become incorporated within a much more broader discussion around the integration of the health, some of the acute service budgets with the social care budgets.
Just another point, perhaps in broader terms. I think, Convener, you've raised a number of issues about how we engage with the service and our partners on changes, whether or not it's changes to, let's say, management or in another area. Each year we issue local delivery plan guidance. In business terms, you would call that business planning guidance. And each year we attach at the back of that our 10 performance management principles about how boards should engage in things like this. So if I take, let's say, the management reduction, certainly principle number 1, that anything we do around performance management must support delivery of the Scottish Government's outcomes. Principle number 2 is about delivering the strategy for improving the quality of patient care. And principle number, let's say, 8, staff must be engaged in target setting and target delivery locally. So all of those principles we expect that boards must adhere to in terms of planning their business for the year ahead, and that includes things like, for example, management cost reductions.
But it certainly gives you cover, because if they fail in any of them, you can say, well, you've agreed to them, but how do we monitor and evaluate? There's a continued question all of the time here. How do we ensure they're doing as you ask?
Okay, we've got at least 2 tiers of scrutiny in this. We have scrutiny locally by boards, and those boards, remember, have both executive and non-executive, staff interests, clinical interests around the board. So there's a significant degree of local scrutiny in terms of how boards conduct their business. We supplement that, as John Matheson has outlined, with 2 more national programmes. One where we have a formal mid-year review of progress, where Scottish Government officials scrutinise with board officials how they're doing plan versus actual. And I'm sure committee members will be aware of what we do around annual reviews, where in public we hold boards to account for the delivery of their plans, not just in terms of their achievement, but how they have achieved it. So I think there's significant levels of scrutiny as we go through the year, regularly, monthly by board members, and on occasion by Scottish Government.
Is the Scottish Government confident that board and board members are carrying out those corporate functions? And because there has been some questions in the past at time of crisis that, well, the board members were not informed enough, or they weren't doing their job, or if it changes of board members, so it's I understand at one end you've got what's expected of them, at the other end you're at a tick spot, but it seems only in crisis that we would examine the role of boards and the members and their capability to provide that corporate governance at a local level. And indeed, plans versus action only appear, or may only appear, at a time of crisis when something's been discovered, rather than... So how do we know what's going on week to week, day to day? What governance takes place there?
Well, of course, that timescale, day to day, week to week, must be local scrutiny. So it's left up to them.
And only when it goes wrong, you get involved.
Local scrutiny on a day to day, week by week basis must be the province of boards. But I do say that we have a system where boards have monthly board meetings held in public. where the public can come along and observe those proceedings. So I think we can be as assured as we can be that there's a good system of governance operating throughout the NHS in Scotland. You just need to compare it with what's happening in other parts of the UK. The Scottish system has got very good integration systems. It's been stable. And I think year on year we can see good Audit Scotland reports on the financial performance of the NHS. And I think the last one, John will be able to give you the quote from this, applauded the NHS for its financial stewardship.
Is that the one that put us on an amber warning at Edmonton, sir? Was that the report?
I don't think so.
The last Audit Scotland report to the Audit Committee, was there not a comment about the amber warning? Was that the report you're referring to?
I'm referring to the fact that I think that Audit Scotland have passed those accounts. They are external auditors in many boards and have signed off those accounts. So I think generally the financial stewardship of NHS in Scotland is satisfactory.
Is there any other member? Drew Smith.
Thank you, Convener. I mean, it's just to return to this issue around national education for Scotland, and you know, I'm sure you'll have had the chance to review the evidence that we had from them last week. But I mean, I suppose there's a frustration in the committee understanding that there are real cost pressures and budgetary challenges within the National Health Service, and clearly there is a role that Directors of Finance play to maximise their efficiency at all times, regardless of whether or not we're under that budgetary pressure or whether we're not. And there's therefore, you know, a bit of a disconnect between some of the things that we would just regard as good practice and what is really the impact of where the challenge is more significant. But National Education for Scotland told us last week that they would approach the point in 2014-15 where they would find it difficult to identify more of the savings of the type that they are currently identifying without impacting on the other areas of their provision, which is primarily obviously the training of doctors. What's your reaction to the evidence that they gave us?
My reaction is what we have with the 4 special boards that I detailed earlier is we have an agreement that they will deliver a differential efficiency target up to the end of the current spending review, 2014-15. And they have signed up to that. They have identified that within their financial plans. Some of their efficiency proposals are quite well advanced. Some of them are in the process of being developed. We would then have a further conversation with those 4 boards about what further potential there is beyond 2014. So at the moment, we only have an expectation, and they only have given a commitment that they will deliver that differential efficiency position up to 2014. And that's our clear understanding with them. And then further conversations as part of the next spending review. But the opportunities within the special boards, I mean, I'll give you the example of Giles Square out in the west of Edinburgh, where we now have 4 of the special boards co-located, or we will do by December when Health Scotland move in, co-located within those premises. And the potential there for shared services benefit around facilities, around IT, around HR, etc., is quite significant. So these are the areas that we're encouraging them to look at, how they provide and how they deliver backroom services.
There's a tension in all of this, isn't there? Because those are all the things that you should be doing anyway. That means that a lot of those costs are waste, and we would want to eliminate those costs as much as we can. And of course, there'll be learning as we go on. So it's not necessarily to blame people for why a waste has arisen. But the evidence that we heard from them seemed to be suggesting that you hit a point, you know, where switching off the lights simply doesn't cut it anymore in terms of bringing down the bills that some of these boards have to pay. Do you think it is possible, for how long into the future can you go on asking the kinds of efficiency savings that you're asking from these organisations without it having an impact on the services that they're there to deliver?
That's the precise point I've made, that we have confidence that they can deliver that for the next couple of years, and then we will have that conversation around them in terms of what the potential is. And that conversation would include recognising that a very significant proportion of the NES budget, National Education Scotland budget, is areas where no efficiencies can be delivered. So that would have to recognise that. But your point is also a telling point, that if there is further opportunity there, you described it as waste, if there is further opportunity there, then we have a responsibility in terms of taxpayers' money to be looking to take advantage of that opportunity.
Thanks. One final question from me in regards to another issue that we're dealing with and we'll be returning to very shortly in terms of access to medicines, and some questions are emerging in regards to, for example, if prices of new medicines were negotiated between NHS Scotland and the pharma companies in the light of an SMC initial assessment, would this help boards, do you think, because it might lead to lower prices, or would it hinder them because the size of the negotiated change in the price is unpredictable?
It's a question that's impossible to answer until we get into the detail of those discussions. It has the potential to be supportive, but we'd have to see what the outcome of those discussions are. We are trying to work very closely with the pharmaceutical industry in terms of not just drug pricing, but also how we work in partnership with them around research and innovation. So we're trying to recognise that they are business organisations who have business requirements, but also that they have the potential to work with us and they support us and us to support them around research and innovation. So in terms of your specific point, we look forward to having those detailed discussions with pharmaceutical industry, but the outcome will be what the outcome will be, and we'll then take a view on where we've ended up in terms of those negotiations.
So in terms of your scenario and your negotiating position, you've discussed that about the pros and cons, the good bits and the bad bits, the bricks not. So what are the pros and cons of it then, if you've not come to a final decision? What are the benefits? What are the downsides?
It's not just about price. It's about the cost effectiveness of the product that we're looking to purchase. So price is a factor, but there are other factors in there. There's also a keenness to ensure that the market is as competitive as possible. One of the reasons why we've had such a significant reduction in the price of atorvastatin recently is the move from a monopoly position to a position where there are a number of potential suppliers in the market. So the ability to keep an open market position is equally important.
But the Scottish Medical Consortium, in the light of their agreement, they would be saying that would be, they would be involved in this process. The SMC in Scotland would be involved in the process rather than someone else.
The SMC would be involved in this process. They would be supported by clinical colleagues, by financial colleagues to carry out these negotiations, and the procurement colleagues would also have a role in respect of that. So we welcome the opportunity to have these negotiations, but we can't prejudge the outcome of those negotiations.
But what sort of discussions have you had in terms of the financial impact here, whether it's good or bad? You must have had. I presume that those people who would be getting into those negotiations would have some sort of view about whether this would be good or bad for us. Is it an opportunity, as we've described? Yes, I'll let you.
Our expectation in terms of these negotiations is it's an opportunity. It's an opportunity that we welcome. And we are expecting a positive outcome from those negotiations in terms of the ability to manage prescribing expenditure within a tight financial envelope.
Really get them cheaper.
More cost effectively. It's not just about price, convener. It's about the broader reliability of supply, etc. So price is a factor, but there are other factors. So we would have an expectation that we would get them more cost effectively.
Bob Doris.
Convener, I just think it's for a bit of clarity around this. So I think it's a comment that has to go in the official report, and that is that when you talk about SMC negotiations, SMC as an institution stand one step away from negotiations, and that's not how it happens within the Scottish system currently. And should any negotiations happen, it would be over a reimbursement rate and not pricing, because pricing is a UK reserved issue, and I just think it's given the complexity of these issues that when we do discuss it, we discuss it in a way where we're comparing apples with apples and we get the factual situation right. But I also note, and we'll discuss this later on in private, of course, that the SMC has said they don't want to be directly involved in negotiations over the pricing or the reimbursement of medicines, and that would be for the others. They want to focus solely on cost effectiveness based on the system that is there, irrespective of how politicians, which is us and the government, decide to change that. I think that's important for accuracy, convener, in terms of the process.
Helpful clarification. The convener mentioned the SMC. I mentioned the procurement colleagues also be involved, and it's procurement colleagues that would be involved in those detailed discussions around price reimbursement.
Yeah, but the emergency evidence is throwing some confusion in there, and it's been described maybe as an opportunity. The government has no view whether it be good or bad if we were negotiating those prices with pharma. I take it that's fair to say from your response.
That is a fair summary. We're keen to enter into those negotiations.
Yeah. Okay, thank you. Any other questions from the committee? No. Thank you very, very much for your time and your evidence to the committee today. Thank you. We go in now, as previously agreed to, private session.